Then you will present what was the data and the variables and the methodology. What we use algorithm, it's latent class analysis, and the result, and some discussion and future work, and also drawbacks of our study. You have in hospital, you have noticed that you have significant heterogeneity in hospitalized patient. The characteristics are different, the disease severity, and also the treatment response, and all this is translated in different outcomes and cost. And we can see on the left, you have what we call a Lorentz curve. It's generally used for economic inequality, and we have used here to represent the difference in cost. And if you look at the picture, you can see that 10% of the, if you look on the x-axis, you will have the cumulative percent of patient, and if you look, you have 90%, which will take about you have 40%. So it's what we call the super utilizator of resource and cost, and you want to focus on this group in order to manage them. So a greater share of hospital expenditure is incurred by a small number of patients that we call super utilizator or high cost user. The main goal of this study was to identify and characterize the entire population of patients who was admitted to the University Hospital of Geneva during 2019 by trying to get cluster of patients who will be similar. Among this cluster, you will have those who characterize high cost user compared to the remaining 90% of patients according to their characteristics. We collect for each patient the primary diagnosis, which was coded with what we call ICD code, which is international classification disease. We have about 70,000 different codes. And you also collect different variables like type of admission, emergency department, and where the patient go after the stay at the hospital, go at home, acute care, and so on. And what we call also the comorbidity score, which is a score because each patient could have a lot of disease, and the more disease he have, the more the comorbidity score will be high. The data you have about each year in the hospital of Geneva, you have about 48,000 of inpatient stays. And we have about in our study, I think you keep about 30,000 patients. Then the method we use is called latent class analysis, which is a method coming from statistical, and it was used in 1950, and now there are a lot of people now that use this kind of techniques. The idea is that it's based on similarity in response patterns rather than distance between respondents. If you want to do clustering, traditional approach will be mean, hierarchical, and so on. And all these methods are based on distance. Here, latent class analysis is based on probability. And we use maximal likelihood and posterior mode parameter estimation like expectation maximization algorithm to get the different parameters of the LCA. What's very interesting in our case, it's that you have data, and all the variables are categorical. And for traditional clustering method like K-means, you have to encode these variables in order to use these techniques. For example, you can do a one-hot encoding, but you can imagine that with a huge number of variables, using one-hot encoding will be very difficult. So, because it's a statistical method, you can use some statistical tests to compare different models. You use also random sets of starting points to avoid local solution, and missing data is not a major problem, but in our case, you haven't a lot of missing data. So why latent? Because we call the latent is variables that not exist. For example, behavior of someone. And for us, this latent class, this group, will be the cluster. We have make a little array, and you can see that our variables are discrete, and the latent group are also discrete. So you are in the case of latent class analysis. In the picture, you have LCA, and you have all the class or groups on the right, and you have all the variables on the left. Variables are called manifest variable, and the class are called structural model. Latent class analysis is a method of mixture. It's kind of mixture of probability, and you are going to try to you have, in this case, you have a matrix X. Each line of the matrix will be a patient, and each column will be a variable, for example, sex, diagnosis, and so on. And it's the first thing you are going to find is the probability of one patient. You have here you have the formula, which is the sum of G to big G. G is the number of groups. Tau G is a parameter which will be what we will call here the mixing probabilities. And you have the probability given the fact that you are in group G of the individual will be in these groups. The first equation number one, is the translation of the mixture of probabilities. Then you are looking for a model-based latent class analysis, and you have how we call a property which is the independence of the variables. Because of this independence, you can express the probability of given the group G of the variable xm as a product of all different probability of the different category of the variables. Each variables have a number of categories. For example, the sex, you have two categories. You will have C equal 1 to 2. Cm will be equal to 2. And theta GMC will be the probability that given the class G of the variable. And on other things is the indicator function. If you have a variable and this variable have the category man, it will be 1, and it will be taken in account of this product. Then you can translate it, and you have the overall densities, the last line of the probability of each patient to be in the different groups. To evaluate this, the different models, here the different models will be the different number of groups. You will have a lot of measurements to fit our model, and you will have the traditional criteria of statistics, the big egg, and also some special tests like low Mandel-Rubin test, and also what we call substantive interpretation. If you have some knowledge about the domain, you will have substantive interpretation. So you have here just a little picture which is representing each criteria you used, and you will based on this trade-off between all this and this, you choose a 8-class model as a final model. Just a word on our approach, because I will then give the la parole à Pascal. It's concerning when we have a comorbidity index, which is Elix-Hauser score, and we didn't find anything in spite of the fact that we know that it's important to characterize super user, and we think it's because our data are very imbalanced, and we should have used an approach like SMOT to oversample or downsample in order to have a distribution which is well balanced. Thank you. I give the parole à Pascal.
Thank you, Gilles.
Yes.
I hope everybody can hear me well. If not, please let me know. So thank you very much to the organizers of the conference for inviting Gilles and I. We're very happy to be there and happy to share with you the result of this analysis that Gilles conducted. Gilles built the model, and as Gilles indicated to you in the introduction, I am a statistician. I'm actually an actuary, healthcare actuaries by training, but I'm also a qualitician. So my work at the University Hospital of Geneva is to measure the improvement, or at least the value, the added value of our quality improvement efforts throughout the hospitals. And therefore, the model, I think, may be quite revealing and hopefully quite helpful in that respect. And so let me just walk you through a few of the results. More of the results are available in the paper that I believe will be available to all of you through the proceedings of the conference. As Gilles mentioned to you, I will illustrate as I go through the results. Something important is that, well, once you build a mathematical model through LCA, for example, well, it's always necessary to check the credibility of your model. And so we were happy that common sense, in essence, of pattern of utilizations of different groups of patients were respected in the different groups of the model, in the 8 groups of the models. And so the first table you have in front of you is patient characteristics, gender and status distribution of patient, whether they are single or couple, and then the age distribution of patient. And what you can see, oh, Gilles is going to have to, that's going to be a little bit tricky. Gilles, you're going to have to click so as to animate. The slide is animated. And so if Gilles click once,
yes,
you see that, thank you, Gilles. You see that first thing we see appearing is a group that has 100% women. Well, that makes sense. In a population of patients taking care in a large hospital, you expect pregnancy to be one of your large activity. And so having a group that includes only women seems to make sense. Gilles, if you want to click next. And then you see, as far as the status of the patients, well, you see 2 groups, 6 and 8, which want only single patients. Gilles, next. Now, if you look at the age brackets, then you see that group 3 of women, well, you expect them to be young adult, and that's exactly what you see in the age bracket. And so that makes sense from the credibility of the model. And then you have this group 7, doesn't show in terms of the gender or the patient status, but then when you look at the age group, you would say, oh, this group is kind of your elderly group. And so you keep that in mind, and then we're going to, Gilles, when you click one more time, please. And then you also have another group that appears that is very young patients. And so now you kind of see a little mapping of the patient that are appearing. Gilles, next slide, please. So then we move at the mode of admission. That's always very important when you look at clinical activity in your hospital. Patient enter through the ED or other means. And then patients are released from the hospital at home or in rehab or in other institution. And so we look at that as well across those 8 groups. Click, Gilles, please. And then you see here that there are three groups that comes out, and those are the one mostly answering, well, two of them, I'm sorry, group number 2 and group number 7, significantly answering for the ED. And then from a utilization of care, that's something that you want to pay attention to. And then there is this group 6, which basically never use the ED. But if you remember, this group is also one of the younger group. And so that's also kind of telling. Next, please. So now when you look at where did those patients go after their stay in the hospital, well, you see that group 1, 97% of the patient went home. You see the same thing for group 3. Remember, group 3 is the women group. And then group 6 and 8 also have a very high majority of the patient going home. And so that gives us a little bit more clues as to what's happening to this patient by groups. Next slide, please. So then we looked at diagnosis. This is what Gilles was telling you. This is based on what is called ICD-10 code. So that's just a coding system of diagnosis across the hospital. Those are called primary diagnoses, as there are multiple diagnoses that are included during the hospital stay of a patient, but we focus on primary diagnosis. And then you can see we just group them into the most important categories, which is in your left-hand side. And then Gilles, if you click, what's interesting is something we didn't really expect. Well, you expect the group 3, again, that's your women group, if you remember. And you see that the diagnosis, of course, concerned women issues. And that makes sense. And that's what Gilles was telling us, that, well, when you build an LCA model, make sure that from a common sense perspective, in terms of describing your data, well, the model really makes sense. And it seems to be making sense as far as only keeping women-related diagnosis for group 3. Group 4, what's interesting is that 90% of that group has diagnosis related to operations on musculoskeletal systems. And so that now refines the model. You get a little bit more granularity into your model, and you start to say, oh, look, here is a diagnosis that seems to pop out on this group 4, and that's probably something we want to look at. And then we have at the bottom of the screen, then you have another group, group 1, where it seems like 35% of the patients seems to be having a diagnosis around digestive systems and others. And then there are two groups, group 2 and group 6, where you have no procedures, no diagnosis. That could be for multiple reasons. Either the data didn't capture it, or either it's miscoded, or whatever have you, or maybe all of this is just not a diagnosis that fell within those categories that we showed you, and maybe it's some others that that we didn't include in showing you this table. Next slide, please. And so then we looked at clinical outcome, and then this cost percentile, which is basically the ranking of patients based on their cost. And then you see that Gilles, if you can click, please. Well, you see that what really pops out here is only one group, and that's really our high utilizers, as Gilles mentioned, and that's our group 5, which previously in the other table that we showed you just didn't seem to show up really significantly. But here, with respect to these costs, well, first in terms of the top 10 percentile, remember what Gilles said, he said, well, these are the people who cost the 10th percentile the most, but also utilize 50% of the resources. And then this group 5 literally pops out at you. And then you can see that it translates into a lot many more ambulatory visits. 40% of that group has 10 or more ambulatory visits. So not only do they use a lot of acute care resources, but they also use a lot of ambulatory resources through our system. And there again, it has more, this group has more than 2 admissions within 2019. Next slide, please. And so then we start to look at clinical outcome, continuing with numbers of treatment, labs, and medication. So that tend to be associated with high cost in healthcare systems. And Gilles, if you want to click, please. And there again, what pops out really out of all the other group, or maybe with the exception of of group 7 when you look at number of labs, which will be interesting to investigate a little bit, but it again is this group 5. So group 5 again, this we felt was really the group of high utilizers, pretty much identify all by itself in that group 5 with very high number of treatments, very high number of tests, and very high number of medications. Next slide. And so in conclusion, if you want, and I'll Gilles, if you would like, just jump in any time. As we try to show you, we believe that this LCA clustering model generating in our data A groups, generate A groups with very distinctive characteristics as we try to show you. We also believe that cluster analysis, therefore, lend itself to identifying similar groups of complex patients from a very large heterogeneous populations. In our case, as I pointed out to you, group 6, probably the young patients, group 3, the women-only patient, group 4, the musculoskeletal patients, and finally, super utilizers, group 5, I think we're pretty much well identified. And that's quite interesting now in terms of implications. Why? Because, well, the method needs to be refined, it needs to be retested, it needs to be create more credibility in terms of separating groups of like patients. But that said, this is a start for a hospital or any other institution using its own data to start to think in terms of having groups that probably utilize medical resources the same way. I mean, single women, maternity pregnancies will use certain resources of your hospital the same way. Young patients will use resources of your hospital the same way. Patient with musculoskeletal problems will use resources of your hospital the same way. And then finally, super utilizers will also probably use resources a certain ways. And so using these methods that we can probably think of ways to more specifically target these subgroups and just create therefore interventions through the hospitals that might actually better target the needs of those patients and hopefully improve outcomes and reduce cost. And so with that said, I'll just, Gilles, tell you about the future work. Gilles?
Yes. We're going to test the model on different years. And also you are going, as I already said, to rebalance the data. And you are going to doing this approach on more specific subset of patients like heart failure or diabetes. That will be the future work you are going to do. That's all. And here you have in the article a few reference on LCA. And thank you for your attention. And if you have any questions,